Hi everyone, welcome to my theatre. In this movie, we will be learning about the optic disc changes in glaucoma. Well, we very well know that in the definition of glaucoma, we say that there is glaucoma when there is a specific kind of optic disc change and its corresponding visual field defect, which means the most important thing that helps us to diagnose glaucoma is the optic disc change. So let us know what are the optic disc changes that happen in the glaucoma. Well, before knowing the optic disc changes, let us just understand how the optic disc looks like. Well, we know how the optic disc looks like, but just for a recap, this is the fundus and this is the fundus of which eye? We know that the optic disc is always present nasally, which means here lies the nose. And if here lies the nose, on this side if the nose lies, then which eye is this? This is the right eye, because this is the nose, this is the right eye, and that is the left eye. And then which part of it is the optic disc? The one inside the square is the optic disc. And what are the parts of the optic disc? The parts of the optic disc are, we have basically, well, we will learn about it, but before that, let us know how is the optic disc formed. This also, I hope that you already know how the optic disc is formed. The optic disc is basically formed because of the nerve fibers which come from the entire retina. The nerve fibers come from the entire retina and they exit the eye through the lamina cribrosa of the sclera. And because of this gathering of the optic nerve fibers and its exit at one point, that is the lamina cribrosa of the sclera, that is the place where the optic disc is formed or the optic disc is situated. So here, as you can see, we have many kind of fibers. We have these fibers which are the superior arcuate fibers. Why arcuate? Because they form an arc which is present on the temporal side. And then these are the radial fibers, the superior and the inferior radial fibers, the superior and the inferior arcuate fibers, and in the center we have the papillomacular bundle. So these are the different kind of fibers that are present in the optic disc. And all these fibers, as you can see in this cross section, all these fibers, they aggregate. You can see that these are the peripheral fibers which pass in the periphery, and these are the central fibers near the optic disc which pass in the center. But basically all these fibers, they aggregate and move out of the eye through the lamina cribrosa and forms the optic disc. Now what are the parts of the optic disc? We will try to understand the optic disc three-dimensionally. This is one structure in the eye where we need to understand it three-dimensionally very well. Why? Because the diagnosis of glaucoma is based on our three-dimensional appreciation of the optic disc. Hence, we need to really understand how the optic disc looks in three dimension. And how does it look? It looks like this. It looks like an egg. So why do I say that it looks like an egg? Because the nerve fibers which come from all around the eye, the superior arcuate, the inferior arcuate, the papillomacular bundle, the superior temporal, the inferior temporal, every nerve fiber which comes, it moves out of the eye through this part of the egg. Through this part of the egg. But this part, the depressed part of the egg, it doesn't have any nerve fibers. Basically, all the nerve fibers, they pass through the periphery of the egg, and the central depressed part forms the cup. So this is the entire optic disc structure. This is not, but this is similar. This thing is similar to the optic disc, where we have a depression in the center, and this depression is known as the optic cup, and we have a rim all around which contains the nerve fibers, which is the neuroretinal rim. And the entire thing is your optic disc. And since the entire thing is your optic disc, we get a ratio, and that is the cup disc ratio. When the length of this is to the length of this is the cup disc ratio. The length of this divided by the length of this is the cup disc ratio. So these are certain things which we need to three-dimensionally understand when we are talking about the optic disc. One is the optic cup, one is the neuroretinal rim, and one is the cup disc ratio. These things need to be understood. So now in real life, how does the optic disc looks like? It looks something like this. Exactly like the egg. When we see it three-dimensionally, we can appreciate that there is a cup in the center and there are nerve fibers all around in the periphery, just like the egg. And this cup is the optic cup, and the entire periphery forms the neuroretinal rim. And the ratio of this cup, the diameter of this cup divided by the diameter of the entire optic disc forms the cup disc ratio. So this is how the optic disc grossly looks like. I mean, I told you everything that is important for you to understand glaucoma. Okay. Now let us understand what are the changes that happens in optic disc when we have glaucoma. Well, from pathogenesis, you know that whatever be the risk factor, whatever be the etiology, whatever be the risk factors, finally what happens is there is a damage to the nerve fiber layer of the retina, which means there is a damage to the axons which form the nerve, which forms the optic nerve. So this is the final thing that happens. And if there is a damage to the axons, that damage will be reflected in the optic disc, and when we see it through the slit lamp biomicroscopy, we appreciate those changes and we diagnose glaucoma. Okay. So one thing you have to remember, and that thing is the damage of the nerve fiber layer. So whatever changes I will say in the optic disc, everything is related to the damage to the nerve fiber layer of the retina, which is being reflected in the retina as well as in the optic disc. Okay. So now this is how the normal disc looks like. We already know how the normal disc looks like, and this is a glaucomatous disc. And what do we see in glaucomatous disc? Well, we will see many things, but the first thing that we see is here you can see that the neuroretinal rim is thicker and the cup is smaller. But since there is damage to the nerve fiber layer, we know that the nerve fiber layer forms the neuroretinal rim, and now there is damage to the neuroretinal rim. And when there is damage to the neuroretinal rim, this nerve fiber layer will become thinner. The neuroretinal rim is damaged, so the nerve fiber layer will become thinner. So what do we see here? We see a thinning of the neuroretinal rim. That is the first thing. Well, that can be the first thing, that can be the second thing. What comes after what is not very clear. Sometimes the patient may present with advanced changes, sometimes the patient may present with very early changes, but usually the thinning of the neuroretinal ring is the first thing to happen. Why? Because the nerve fiber layer are damaged. Okay. So what is the first thing? It is the thinning of the neuroretinal rim. And it's not a big thing to deal with. It's very easy to understand that thinning of the neuroretinal rim happens because of the damage to the nerve fiber layer. Now what is the second thing to happen? The second thing to happen is the increase in cup disc ratio. Well, is it a thing? It's actually not a thing, because this thinning of the neuroretinal rim automatically will cause an increase in cup disc ratio. When this will become thin, obviously the cup size will become larger, and when the cup size will become larger, the ratio of the cup is to disc will go up. So because of this thinning of the neuroretinal rim, the second thing that happens is an increase in cup disc ratio. So basically this is not a new thing to happen, but when we talk about the finding, this is an important finding to be documented. Why this is not a new thing? Because this thing happens just because there is thinning of the neuroretinal rim. The thinning of the neuroretinal rim causes an increase in cup disc ratio. So these are the two things that happens. Now what is the third thing that happens? The third thing that happens is, as the neuroretinal rim becomes thinner and thinner, at one point the neuroretinal rim becomes so thin that we can appreciate the lamina cribrosa of the sclera. The lamina cribrosa of the sclera becomes visible to us at the cup of the optic disc, and that is known as the laminar dot sign. In the lamina cribrosa, we will see several dots, which is known as the laminar dot sign. So the third thing to happen is the laminar dot sign. So these are the dots. You can see that there are so many dots. These are nothing but just because the optic nerve fibers are damaged, we can see the sclera through it, giving rise to the appearance of the laminar dot sign. So first is the thinning of the neuroretinal rim, then second is increase in cup disc ratio, and third is the laminar dot sign. Now what next? Well, the damage is happening, the nerve fibers are gradually reducing in size, and that reflection of whatever damage is happening, we also see that reflection in the retina, because the nerve fibers, they come all throughout with the retina and they merge to form the optic disc. So we also see that damage happening in the retina, and that is visible as a wedge shaped defect. See, this is how a wedge looks like, right? The wedge is like a hammer kind of a thing, and this is how a wedge looks like. And when there is damage to this nerve fiber layer of the retina, we see a wedge shaped defect. This is a wedge shaped defect. Here we see a wedge shaped defect, which means we see that the nerve fiber layer looks dull in color. I mean, it looks ischemic, dull in color, which is usually appreciated better in the green light. Otherwise, it's a bit difficult to appreciate. Either red free filter or green light helps us appreciate this wedge defect better. Here you can see it better in comparison to these two pictures. Here you can appreciate this wedge better. It's hard to find, but this is one of the findings that we see. Okay. Now what next? As the thinning continues, what happens is, when we talk about the fibers, that is the temporal fibers and the arcuate fibers and the radial fibers, the arcuate fibers are present temporally and the radial fibers are present nasally. So here I want to give you a piece of information, and which we will be learning more in the visual field when we will be learning visual field, and that is the arcuate fibers which are present temporally are more sensitive to damage, and the radial fibers are less sensitive to damage. And just because the arcuate fibers are more sensitive to damage, what will happen is the vessels which are present, they will be dragged nasally, because the nasal has more fibers which will need more amount of blood. Thus, the blood vessels which are there, they will be the blood vessels like the central retinal artery, the central retinal vein, which comes which enters inside the retina, which exits out of the retina. So those things will be shifted nasally because of the damage of the temporal nerve fibers, which we call is nasalization of vessels. Okay, so this is the fifth thing that we see, and that is nasalization of central retinal artery and central retinal vein. Okay, now what more do we see? After that, as the damage continues, we know that the central retinal artery enters the eye through this through this lamina cribrosa. Central retinal vein exits the eye through this lamina cribrosa. So what happens is, when there is entry of the central retinal artery, the central retinal artery, when it enters, it actually, just because the cup size has increased, the cup is increasing in size. So initially the cup is like this, but gradually as it increases in size, there is excavation, and just because there is excavation of the cup, usually the blood vessels, they were coming down and coming out, but now there is a depression inside, there is an excavation inside, because there is so much of damage to the nerve fiber layer that has happened, and because of this excavation, the nerve fibers won't be able to come straight, rather they will come down, enter into the depression and then come out. So this will be the path of the blood vessels which will be seen in case of glaucoma, and that is known as the bayoneting sign. So this is the sixth finding, and that is the bayoneting sign. And why does it happen? It happens because of the excavation of the optic cup. It happens because of the excavation of the optic cup. Okay. Now, what is the seventh finding? The seventh finding is sometimes we also see a flame-shaped hemorrhage near the optic disc. Here you can see that there is a hemorrhage. So sometimes we see a flame-shaped hemorrhage near the optic disc, and this flame-shaped hemorrhage is usually seen in normotensive patients, in normotensive glaucoma, but it can also be seen in normal patients. But it is very characteristic of normotensive patients, which happens because of ischemia. Fine. So these are the changes. Basically, we read about. Okay, this is the hemorrhage. Fine. So basically, these are the main changes that we see in glaucoma, which are 7 in number. So what are those changes? First is your thinning of the neuroretinal ring. Second, because of thinning of neuroretinal ring, there is increase in the cup disc ratio. Third, there is this wedge-shaped defect in the retina. Fourth, there is nasal shifting of the vessels. Fifth, there is bayoneting sign. Sixth, there is this blood vessel, like we see the flame-shaped hemorrhage near the optic disc. So these are the changes, and one change we are missing. And what is that? Okay, the laminar dot sign. Fine. So these are the 7 things that we see in your optic disc changes when there is a patient with glaucoma. Now there is a very popular conventional rule which we call is ISNT rule, but this ISNT rule is no more valid. That's why we will not be going into this ISNT rule, because that was carrying a lot of significance in the past, but now we don't give any importance to this. Fine. So now the question is, we know that there is a optic disc change, but how do we evaluate the optic disc? For example, there is a change in the heart, we put the stetho and we listen to the murmur or whatever, we listen to the heart sounds. So in a similar way, when we know that there is some optic disc changes, we need to be able to see the optic disc to really appreciate any change. And how do we see the optic disc? Well, we see the optic disc in 3 ways. We can see it in 3 ways. First, and the most popular technique is a slit lamp biomicroscopy. I hope you people must have seen a slit lamp. In the slit lamp, we use a 90D lens. The slit lamp already has its magnification. Along with that, we use a 90D lens, and with both the eyes open, we look at the disc. So this is how a slit lamp biomicroscopy looks like. This is the slit lamp and this is the 90D lens. So the doctor sits in the slit lamp and puts the 90D lens in front of the eye and sees the optic disc. Well, this is the gold standard way. Why it's the gold standard way? Because the slit lamp, this is the magnification system of the slit lamp. The slit lamp has a magnification, the 90D has a magnification, which means the optic disc which we will see will be highly magnified. So this is the advantage number 1. And second advantage is we see the optic disc with both eyes open. We see the optic disc binocularly. And when we see any structure binocularly, we can appreciate the depth. You know that the binocularity has a very important function, and that is depth appreciation. And when we can see the optic disc binocularly, we can appreciate the depth. So these are the 2 important things because of which this is the gold standard. So why it's the gold standard test and the best test? That is because of the magnification it provides, which is the magnification of the slit lamp and the magnification of the 90D. And the second is the binocularity. The binocularity has a very important role in appreciation of the optic disc, as we are trying to know the cup disc ratio, the depth of the cup and other things. Now what is the second best? The second best is a direct ophthalmoscopy. This is a direct ophthalmoscope where we see the patient, where the right eye of the patient, the doctor tries to see the The right eye of the doctor tries to see the right of the patient. Here again it's just an instrument and we use it we don't use it binocularly, use it monocularly. So it's not that great. And the worst, I mean the least not a very great way to see the optic disc is your indirect ophthalmoscopy. This indirect ophthalmoscopy is binocular. It provides binocularity, but it is binocular, but the magnification is very less. The magnification is very less. This is uniocular, so we don't consider it that much. Even though this is binocular, the magnification is very less. So the answer to the question of the best way to see the optic disc is your slit lamp biomicroscopy. Slit lamp is this one, and biomicroscopy. We see the optic disc with the help of a lens while we are setting in the slit lamp. Fine. So this was briefly about the most important thing that happens in glaucoma, which actually defines glaucoma. The glaucoma definition is altogether based on the specific optic disc changes and its mirror image, that is the visual field changes. Optic disc changes has happened, the mirror image visual field changes has happened, means we define glaucoma. We don't need anything else to define or diagnose glaucoma apart from this. Even though there are so many things which help us, but these two things are something that is the ultimate thing for the diagnosis of glaucoma. Fine. So the most important thing we have covered briefly, and I hope it was very interesting for you because it was interesting for me. I tried to make it interesting, and okay, I hope you followed, and we will catch up next with the visual field changes. Thank you.